This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. A 70-year-old male patient who has a hypermature, long-standing cataract. The nucleus looks to be very hard, and also he has a calcified capsule, and he is posted for surgery. The original plan was actually to do a toric lens for him, but looking at this complexity, I'm not so sure, because I have decided to perform a manual M-SICS surgery in this patient at present. So what I'm doing now is I'm sitting temporarily. The marks are there for the toric lens, and if everything goes well, then maybe I can still go in and put in the toric lens, because when I do my temporal sclerocorneal tunnel is not very high, so I can still be within the ballpark. That is my guess. But however, in the situation where the things don't go according to plan, then maybe I would abort the toric and put some other lens as well. So the capsule is stained and the antechamber is pressurized with OVD, and time to make the internal entry. About 2 mm inside the limbus, the internal entry is being made. But as it is being extended to the right side, the extreme end has come towards the limbus. This is not the most ideal way to have your inner lip. Inner lip always has to be, in a smile orientation away from the limbus all around. So time to perform the rhexis. I want to have a decent size at larger rhexis, slightly bigger than the pupil, so time to go under the pupil. At this stage, I realized that the rhexis is getting entangled because of this calcific plaque. Nevertheless, I just go in and try to circumvent the capsular plaque and complete the rhexis. So this stage, I realized that the rhexis is unusually large in that area. Rhexis is done, and time to maneuver the nucleus out. So using 2 Sinskey hooks, I'm just maneuvering the nucleus out of the bag into the antechamber. I'm just weighing my pros and cons of the toric lens. Because the rhexis is not gone in the most predictable way, I'm a little bit skeptical of the toric lens. Anyway, the nucleus now has to be pulled out of the bag using the phaco sandwich technique, and it comes out quite comfortably. The pupil has come down in size, so the cortex aspiration becomes a little bit of a tricky situation. So because the rhexis is not so clearly visualized on my left hand side, I decided to abort the toric lens, and I decided to go in with a multi-piece lens, because even if one of the haptic is in the sulcus, the chances of developing chronic uveitis or UGH syndrome is significantly lesser with the multi-piece lens, and that's the reason why I have foregone the toric intraocular lens, and the multi-piece lens should be fine. So I go in behind the lens and do some irrigation to remove the OVD, and the lens looks to be stable, and I want to remove the OVD in front of the lens. Now at this stage, the pupil on the left side starts to behave a little bit abnormal, and this is suspicious. Something is wrong here. So a little bit of a zooming in shows that there seems to be a vitreous prolapse. There's a demarcation line clearly seen, and this could be the bag which is shifted towards the right hand side, or could be a peripheral PC tear. There is some reason why the vitreous is prolapsed out from the left side. So whenever you see a pupil which is kinked like this, it's invariably an indicator that something is coming out through that area, and invariably that would be most likely the vitreous. So time to do the vitrectomy. So usually before going into the antechamber, I first go in and do a little bit of vitrectomy at the wound itself. So this will cut off all the strands which has come across the pupil towards the wound, and that would make the pupil round. Diluted triamcinolone acetate is used to stain the vitreous, and now it is the time to perform the anti-vitrectomy. Again, I need to ask myself that this looks to be a transzonular prolapse vitreous, most likely, and is it better to go in through the pars plana, or the anti-approach is good enough? Now, because most of the job is done, the lens is already in place, and the amount of vitreous prolapse doesn't seem to be quite large. So I thought I can manage with the limbal route itself, and that's what I'm trying to do. Again, as I keep telling, when you're cutting very close to the iris, it's important that your vacuum and flow rate have to be very low. The flow rate is 12, vacuum is around 200. This ensures that you're not cutting any structure inadvertently. It is always we're cutting the structure which we want to. We're working very close to the pupillary margin, but still staying away from it, not cutting it. Each vitreous fibril is identified and cut. And obviously some vitreous would still be lingering around behind the pupil at the edge of the optic. But I think the one which is removed in front, that should be fine, I presume. So before closing, I just want to confirm that the lens is well centered. So I go in with my Y hook, retract the pupil and see that everything is alright. Now it's an important step because we don't want any surprises post-op. So what I can understand at this stage is that at least the proximal haptic seems to be the sulcus. I'm not sure about the distal haptic. Time to close. One more check with the triamcinolone state just to be doubly sure that there's no vitreous. And as I told you in the initial part, I was not happy with the internal lip of the wound on the right hand side, so I thought I'll close the scleral tunnel. In this case, I've consciously used atovicral suture to suture the scleral wound, simply because I'm sitting temporally. Any suturing is going to induce against-wall astigmatism, which is going to worsen the already pre-existing astigmatism. So I'm using the vicryl for the reason that because it's an absorbable suture, so I don't have to release it later on. And it has got reasonable strength to hold the wound together. The conjunctiva is also closed with the atovicral suture. The ports are hydrated, that's it, the case is done. Now, these are the post-op pictures and the patient continues to do well. So in situations where we are not sure about the rexus integrity in the periphery, or we're expecting a zonular weakness and there is every likelihood that the haptic can pop out of the bag and go into the sulcus, in those situations we're better off by opting for a multi-piece lens so that the later side effect of the single piece haptic are minimized. We don't get UGH or chronic uveitis with these haptics or the multi-piece lens. So that was it. Thank you for watching and hope you found this helpful.